Welcome to the St Emlyn's podcast. I'm Iain Beardsell.
And I'm Simon Carley.
And Simon, in an appalling piece of admin, it turns out that we are about to do the review of January's blog posts and podcasts. Faithful listeners will know that we have already released February's review, but for some reason, when we sat down to record February, we forgot January had happened. I know it's a month of darkness and cold, and maybe that's why it had gone out of our mind, but there's so much good stuff in January, we've come back to do it again. So we're going to crack on with January. Before we do, just a quick note, again, to say thank you again to the people at Incrementum for our time in Spain, and to just say they have told us that they will be running Incrementum in 2026. April 22nd to 24th in Murcia. Again, fabulous venue, fabulous people. Mark your card. It's over a year away. So emergency physicians and those of you listening to this podcast probably do not have the attention span to put that in your diary just yet, but we will remind you. But it's happening again. Very exciting stuff.
I'm really looking forward to it. And as I said in their previous podcast, simply the finest tomatoes that you'll ever have in your entire life. Apart from the education, the food and everything else, amazing. Wonderful people.
And we've already been chatting with them about some of the plans, and I think they're taking it to the next level. They're determined to make the sequel better. It's the Godfather trilogy, I think, where part 2 is better than part 1, and part 1 was pretty amazing. So something to look forward to. But we have 4 very high impact papers to chat about this month, Simon. And we're going to go into them to some detail and a few other blog posts as well. There's a bit of pre-hospital bent here, but there's some messages, whether you're working in the emergency department or pre-hospital environment. But we're going to start off with the pre-hospital ECPR study, the sub-30 study. Now, this was published. In fact, you'll notice there's a bit of a trend here. There's quite a few familiar names in amongst what we're doing today. But this was published in Resuscitation just earlier this year. And this was about the ability to get patients on pump, on ECPR, ECMO, pre-hospitally within 30 minutes. And it's worth a think about because this has now progressed into London HEMS as a particular UK service doing this.
Yeah, it's really interesting because I saw the results of this given out at one of the conferences. I think it was at the Big Sick. And I thought at the time it was a really interesting study and really ambitious to get somebody onto ECMO within 30 minutes. And clearly you can only do that in a metropolis where you've got good access and good roads and high quality people, all of those kind of things. So it's really interesting to look. If you can do it in London, then maybe you could do it in somewhere like Manchester or Southampton. It was a feasibility trial. So it's not really doing comparisons or anything like that. Open label, prospective, single arm feasibility trial. Can we do this? Can we achieve this sub 30 target? What they did is they looked over a 27-day period when they were recruiting. They identified 43 patients who might be suitable. They dispatched to 18 of those patients because these numbers are quite important when you break it down. Remember, we're talking about a fairly big area of London. When they got there, 5 patients met criteria for going on to ECMO, and they managed to achieve that. The time from the arrest to getting to scene averaged about 14 minutes. The time to get onto cannulation was an average of 47 minutes, ranging between 37 and 59. So you can already see that they didn't achieve the sub 30. And in terms of outcomes, 3 patients had care withdrawal. 2 survived, but 1 survived with a modified Rankin score of 4, the other with 5. And just to remind you, a modified Rankin score of 5 is severely disabled, for example, bedridden, incontinent, and requiring constant care. I thought this study was interesting because it came with a bit of a fanfare, and I think it's really fantastic work. I'm really pleased that people have done it. And it's interesting that we're one of the few countries where ECPR is not available as widely as it is on places like the continent. But the numbers on this, and it is a feasibility study, but actually the outcomes weren't terribly satisfying. But then, would you expect them to be? They're setting up a service, it's early days, it's small numbers. Interesting. It asks as many questions as it answers, this study, to me.
But I'm really glad we're asking these questions. And we've talked a lot recently about improving care for the cardiac arrest patient, particularly the patient with the shockable rhythm. And 4 of the 5 patients had shockable rhythms from these cardiac arrests. And those are the ones for me that I am more and more convinced we should be getting better outcomes for if we can get people to them, defibrillators to them. And if that doesn't work, then onto pump, whatever it might be. But it's a brave thing to do, but I think it is the next step. But I do wonder whether this will turn out that a bit like, I suppose we've seen the Reboa balloon burst a little bit, whether in the end we will come down to this not necessarily being the thing. But when we spoke to Alice Houghton from France back in Tactical Trauma, and there's a podcast you can hear about, they've been doing it for 10 years. And when I said to Alice, as part of that podcast, so this happens infrequently, she said, no, we're doing this most days. So it can happen in a large metropolis. You just need the service to make it happen. And good for them for giving it a go. But I do, as I've said before, wonder about, in amongst all the other stuff we're doing, whether these smaller number interventions will get the support they need when we've got so many other people who need help and support with the more everyday type thing.
But then if you can get people who are working age, families, really productive members of society, and return them to a normal working life with great prospects, then the economic argument actually adds up quite well. There is also another economic argument, which is in other health economies. I don't think it will come to the UK anytime soon, although it might do in a slightly different form, is that there is a group of patients who you might be able to put on ECMO who may not survive, but as part of a cardiac arrest post-death protocol for organ transplantation. And that's certainly been done in places like Spain. Santander has got a really good program running around that. And if you start looking at the economic benefits of improving the number of people who have organs available for transplant, the economic argument becomes very positive because, as you know, dialysis is an absolute nightmare financially, but particularly for patients, it's an absolute disaster. And renal transplantation is one of those fantastic things you can do to any person with any disease, really. It's amazing.
So have a read of the paper yourself. It's in Resuscitation. It's called the Sub-30 Feasibility Study of Prehospital Extracorporeal Membrane Oxygenation in Patients with Refractory Out-of-Hospital Cardiac Arrest in London. And some really familiar names on there, including Gareth Davis, our old friend from London Hems, who's now up in the Isle of Man. Very much worth having a read. Seek it out in Resuscitation. Have a read of the blog. And as ever, we'd love you to comment on the blog post. Tell us what you think. It's really great to have a conversation about this. And the more we can talk about these things that are really big deals for us in resuscitation and pre-hospital care, then the more voices get heard. Simon, the next paper is one from SJ Trem, the Scandinavian Journal of Trauma and Resuscitation and Emergency Medicine, a great journal, open access, but publishes all sorts of stuff that is really relevant to those of us working day to day in emergency departments, pre-hospital. This is about time to emergency anesthesia. And is it quicker, better to do that in the pre-hospital environment or to do in the emergency department? And this is a topic that I think is really worth thinking about, something we talk about a lot in pre-hospital services. We consider a lot in the emergency department. And here they've looked at a lot of time criteria, and I think it's worth going through a few of them.
It's a constant conversation, isn't it? In hospital colleagues saying, well, you were messing around on scene, putting this guy to sleep. You should have just brought him here. We've got a full anaesthetic team here. We could do it here. It'd be quicker, blah, 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 blah. A conversation as old as pre-hospital care, really. This is quite an interesting study. It's a retrospective study looking at major trauma patients going into a London Trauma Centre. And what they did is they compared the timings for whether or not you got your RSI pre-hospital or whether you got it in the ED. Tried to match the patients up a little bit, and it's a bit tricky to do. Anyway, 209 patients, 103 done pre-hospital, 106 done in the emergency department. Headline figures, you get your RSI quicker if you get it done in the pre-hospital environment. Not a massive surprise, let's face it, because you're doing it and then transporting the patient as opposed to transporting the patient and then doing it. So that's good, I suppose, if you believe that early RSI is good. I do, for things like head injuries particularly, which is a lot of the patients that we end up putting to sleep. So I think that's a positive. But more importantly, they also looked at things like time to CT. And CT, for me, in trauma particularly, I've said this many times, is a real decision point. Getting into the CT scanner, finding out what the injuries are, and then making a definitive plan for how to treat them is really important. We don't take that many patients straight to theatre. Most of our trauma patients, the vast majority, go via CT. So timings for CT, 107 minutes versus 132 minutes, 25-minute difference. I think that's probably clinically important. There are some problems with this study, and it is retrospective. We know that there's all sorts of flaws in that, and you can see that because the pre-hospital patients were sicker. So they're not really comparing apples and apples. The patients were different. But actually, it sounds as if the pre-hospital RSI patients were more complex. Even more important, perhaps, that you've got good control of the airway. The other thing which I thought was interesting here was the actual timing. So there is an actual target for RSI in things like head injuries of about 45 minutes from time of injury, and their average is 64. So clearly quite a long way outside that. Nothing to do with this particular service. I think that's pretty typical everywhere. Achieving that 45-minute target is really hard outside of an urban environment where you can access the patient by road really quickly. I think it's a real toughie, but stretch targets are okay.
This is one of those topics that I think weighs heavily on anybody who does pre-hospital emergency medicine, is when is it right to crack on and do what is a potentially very dangerous procedure in the pre-hospital environment when it's a small group, you're in a less than ideal situation, which admittedly you're trained for, versus just getting in the back of an ambulance and getting them to hospital and getting the intervention. And there's so many other things that go on that you think about when that's happening. It's almost really too hard to try and go through how pre-hospital emergency teams think when it comes to that decision. I know from my time doing pre-hospital emergency medicine, which I must admit I am not doing anymore. I'm not sure if it's a bit like being an alcoholic, that once you're an alcoholic, you've been an alcoholic for the rest of your life. So I don't know if I'm allowed to say I'm a pre-hospital emergency physician. I think once you stop doing it, probably I lose a bit of my credibility. But I remember the thought process for me and how it felt at the roadside or in somebody's house when you're only 10, 15 minutes away by road from a hospital and a team who can help. Undoubtedly, I think a small team gets this done quicker. You know what you're doing. You're working with the same people. You've drilled it. You practiced it. And actually, that can be, from my experience as a trauma team leader, a lot more effective than waiting to get to the emergency department and asking a newer team who've only just formed to do it there and then. So there's definite benefits. I do also know that doing pre-hospital care is one of those things where you get moments of high intensity activity in most services and quite a lot of downtime where you're thinking, studying, training. And wanting the opportunity to do an RSI was also very much at the forefront of, here's my chance to do one. And I wonder sometimes, Simon, this is outside perhaps the realms of the paper, but how much of our decision making is based on, I'm here now, let's crack on, versus I'm here now, it's a better thing to do. Clearly, the people doing this retrospective review, they can demonstrate some time improvements, which aren't that surprising, but patient outcomes are probably the ones I'm most interested in. And I would love to chat to pre-hospital emergency physicians about their thought process by how they decide who's going to get this procedure and who doesn't.
As we said before, there's 2 universal indications for every procedure. 1, the patient requires it. 2, the doctor wants to do it. And only one of those is valid. I think on here, we've assumed that they're all reasonable. I think that's fair. In this paper, the time from the arrival of an RSI capable team, the hospital was actually slightly quicker, actually, which again, may not be that surprising. But I have had the experience of taking patients into particularly complex patients, so things like children, where you may struggle to find somebody who is comfortable to anaesthetize that patient, whereas pre-hospital teams are organised and trained to do.
And there's other things we can do. So down in Southampton, which is a major trauma centre, we've started going direct to CT. So if you have a primary head injured patient with no other injuries, we do have a protocol now where they don't have to come into the emergency department if they have their airway managed and everything is okay to go straight to CT. And we've set up a whole protocol to do that in that belief that time does matter. And as ever, as a trauma team leader, the big thing I worry about is momentum to points. It's easy to think about the time to RSI. It's easy to think about the time to CT. The bit I really worry about, which isn't covered here, is decision inertia that happens afterwards. We're waiting for the report of the scan. We've got the scan. Now what do we do? And sometimes that's the bit that I wish we could look at and stop some of the pontification around, okay, we could do this, we could do this. They do need thought. Of course they do. These are complex patients. But just having the bit of getting the imaging is not the only bit that's important. What do we do now? And all too often teams disperse. We've got them through scan. We've found out they've got this injury. Let's call somebody. And it all slows right down. But I just desperately try and keep that momentum going after the CT has happened to make sure that you don't just slow everything down because we've got the CT. Everyone loses interest a bit and the patient's still sitting there needing something to be done.
You're bringing me some flashbacks there. But yeah, I share those anxieties.
Our next paper is on a similar vein, and this is about maintenance of pre-hospital anaesthesia in trauma patients. And really, this is about variation in practice. This was done in Australia and New Zealand and the UK. And the paper was published by Zane Perkins and Brad Sheridan in BJA Open. You can go and have a read of the paper yourself. As ever, we'd recommend it. But there's a lot of variation about what we're doing in these environments. And it's always struck me as a bit strange that each service, each pre-hospital team had a different thing, a different way of doing stuff. Is there time for us to try and bring that together a bit more?
This was just looking at variation. It's not really telling us what's actually best. It's just telling us people do different things. Most people are keeping people asleep with either ketamine, midazolam, or a combo. Most favourite opiate is fentanyl. But quite a different variation about whether people were giving boluses or infusions. I've used both in different services. So in one service, we use boluses and I can cope with that. In another service, we've used infusions of using 2/3 of the ketamine dose. So 2/3 of the induction dose then goes into a syringe and that's your hourly rate. That kind of works fairly well as well. I quite like infusions because I've got a few things to think about once it's up and running. But it is a bit more of a faff at the beginning to get it set up. I don't know what you've used in the past, Iain, but yeah, I think we need some more information about what's best before we actually make some strong decisions on the basis of this.
And one of the big themes, I think, from all these papers is that there's some really complex thinking that happens by the individuals who are making these decisions. So sometimes having boluses works because you remember, right, I've got to remember to think to do that. I'm going to keep more of an eye on stuff. Sometimes you think if I've got an infusion, what if I forget that it's going and I don't pay full attention? You've got to have everything turned right on. And it will depend a bit on what the patient's demanding of you that you need to think about whilst you're doing stuff. Sometimes patients are relatively straightforward. They've got that isolated head injury, everything's sorted, managed, you're in the back of a vehicle and off you go and you can write your notes. And other times you're absolutely wired for the whole journey in and you're having to think about everything all of the time. And sometimes the decisions about how you're going to do that and what drugs you're going to use are incredibly complicated, and trying to get into people's brains, particularly the people who've done this for years and are really experienced. They're the people who I'd love to chat to and say, so talk me through your thought process with that. The problem I guess we sometimes have is that we don't allow ourselves enough time to go through afterwards. I know there's a robust M&M process, but it doesn't always feel to me like it's that narrative discussion of tell me how you thought at the time. Tell me what it led you to do that in a non-confrontational, supportive environment rather than, oh, you did that and this bad thing happened, or you did that and this good thing happened. How we think, as we've always done at St. Emlyn's, is perhaps the most intriguing and important bit.
Yeah, and the only thing I'd add to this is that all of the things that we do, this is a bit of a pre-hospital month, isn't it? I think pretty much everything that we're talking about, apart from maybe in the next paper, is entirely relevant to emergency medicine practice as well. So we're talking about here about infusions, about keeping people asleep on the journey into hospital. It's exactly the same as the journey to CT or the journey up to theatres or the journey up to ICU.
And Simon, to finish off our paper review for January, before we just mention the other blog posts, this is a real hot topic and probably comes down to what we've just been talking about. And this is about physician-led pre-hospital teams and whether this improves outcomes. Does it make a difference to have doctors in the pre-hospital environment? And again, many people have many opinions, but at least this is trying to put some numbers to it to work out whether or not this is a valid thing. It's not cheap to have doctors in pre-hospital care, and lots of people are paying lots of money, often through charitable donations. So we need to know it works. We can't just assume it does. And I know you've probably got lots of thoughts about this paper. This is again in the Scandinavian Journal of Trauma Resuscitation and Emergency Medicine, SJ Trem.
It was one of those ones that appeared on various social media platforms going, oh my God, this proves that a doctor paramedic team is better than a paramedic team. Look at the outcomes. This paper definitively says this. We're nicely skeptical at St. Emlyn, so we always have a look at the data. The headline figures here are that they've looked at 23 studies, of which one is an RCT. They've done a meta-analysis stroke systematic review on this, and they've looked at mortality rates, and they've done some odds ratios, which give you the idea of whether or not you're better off with one team or the other. Those are adjusted odds ratios for various different factors that we know about, which influence mortality. And they've said that, in their opinion, the physician-led teams have an increased survivability from atherosclerotic cardiac arrest if it's non-shockable, and a decrease in mortality in trauma as well. If that's what you believe and that's what you want to believe, stop listening now and don't bother reading anymore. However, if you delve into it, then it's only one RCT. So a lot of this is observational data. And we do know that observational data, particularly for stuff like this, is really biased because we don't necessarily send the same teams to the same type of patients. So all sorts of things go slightly strange. If you look at the unadjusted odds ratios, pretty much all of the services show an increased mortality with the physician-led teams, probably because they are going to different sorts of patients. And the mortality rates vary enormously in these studies, from very low rates to really quite high rates, suggesting that the patients in the studies are not equal between each other. So you probably shouldn't put them together. And that's evidenced by a very high heterogeneity score, which is a statistical way of looking about whether or not these studies are similar. And the stats would say not particularly. Then you've got the question of what is a doctor and what is a paramedic, which you might think you know. But if you're comparing international studies, a paramedic in Poland is not necessarily the same as a paramedic in Japan, is not the same as a paramedic in the UK. So I think this is one of those studies which is doing its best, and great work by the authors, to try and find where the overall picture is. And then they've done these adjusted odds ratios for factors which we know are important. But I'm not sure that this really is as definitive in terms of either the finding, which I personally believe, but there you go, or the magnitude of the finding because of the variation in who was studied, how it was studied, and what the patients were. And if you've got lots of variety there and you mix them all together, I'm not sure it gives you the best answer in the world.
There are some matters arising that they call them in SJ Trem, some letters to the editor, if you like, that you can go and have a read that do also raise some really important questions about the paper itself. And interestingly, the one paragraph leapt out to me, which said, the authors consistently employed causal language throughout their discussion and conclusions. Given the predominantly observational evidence base, this approach risks overstating findings, potentially misleading clinicians, policymakers, and guideline developers. So there's very much two sides to this story, I think, and it needs deeper thought before you dive onto this bandwagon and think that, yes, this is doctor-paramedic model. It's proved here and we must crack on. I think there's definitely many ways to skin the cat, if you like. But you're a believer, Simon. I know you're a believer. And I think there is definitely a place in a well-formed pre-hospital service for that doctor-paramedic model. How it's funded and who pays for it is a whole other thing. And whether on a cost-benefit analysis it really works, that's another question entirely.
And in the service I work with, we have 3 aircraft, and 2 of which are double CCP aircraft, and 1 of which is a doctor-paramedic aircraft. And we appropriately, or try and appropriately, dispatch those to the right sort of jobs for the right people. And that works, I think. It's pretty good. My favourite jobs in the world, I've got to say, are when I'm on for basics, and I'm backing up the double CCP copter for something like an RSI when the doctor copter may be offline or unavailable because they're already on a job. The doctor plus 2 CCPs, I think, is a fantastic model. It works really well. It's complicated, isn't it?
It's very complicated, and I could do a quick 20 minutes on how I feel about costs of pre-hospital services. 3 helicopters, 10, 12 million pounds a year. It's okay when it's charity funded, isn't it? It feels all right. If we were suddenly to put this into our cash-strapped NHS system, that's a whole other discussion. And not one for today, Simon. Don't worry, I'm not going to drag you into that right now. In January, we had those 4 amazing pre-hospital papers, and there's lots more to read too. Zaf has done an article about the London Trauma Conference and what you could have seen and heard there. Again, highly recommended, annual conference, or every other year sometimes. So keep an eye out for it in December this year coming. More podcasts have been coming out, something about likelihood ratios, one of my favorite statistical topics. So please have a listen to that. Likelihood ratios, dare I say, I believe are the key to all medicine. And then one just to mention a little bit is about 10-second triage, which we recorded in Tactical Trauma with Sean Brayford Harris, because this is something that I think it is worth people knowing about. It's coming out into police services, fire services, pre-hospital services, and it's a really well-designed, thought-through tool about how in a major incident, should heaven forbid you end up at one, you have a means of getting around and making good triage decisions at scene. So Simon, that is January. We've done it out of turn. You've already heard February. We're now going back to January, and very soon you'll hopefully get to hear March. But there's lots to think about, particularly if you're a pre-hospital emergency physician. As ever, the blog site is there. We would love to see your comments on there, love to hear from you. There's a lot to think about, a lot to talk about. And as ever, please do like, subscribe, get involved. If you'd ever want to write for us or get involved more with St. Emlyn's, we're very open to receiving articles. We've got a couple from outside contributors that we're looking at the moment, which will hopefully be published in the very near future. And again, a quick thank you to Galore Pharmaceuticals and Powerful Medical, PM Cardio, who are helping support the podcast and the blog site as we go forward, and lots more exciting stuff to come. Simon, that is January. We'll move on soon to March. It's been great talking.